My name's Juliet Spiller and I'm a consultant in palliative medicine, so I've been working in the field of palliative medicine for over 20 years now, and I've been working across a whole range of settings. I work in hospice, I work in the community, I have worked in hospital palliative care, but community work would include patients who are in care homes, as well, community hospitals, so all the range of settings. Palliative care is life affirming. It's not all just about death and dying. Clearly, when people are dying, it's about making sure that they have the best possible care at the end of life, and that they're comfortable, and that they're dignified, and they have the people that they want around them, and that they're in a setting where they would like to be if possible. Having been working in palliative care for 20 years, I've seen so many people come through crisis and despair to an end of life which did so many amazing things, and I would hate for any individual to miss out on the opportunity of that. I've seen families come together, I've seen conversations happen that would never have happened in any other situation. I've seen amazing memories be created. I've seen families working through really hard times, and it brings people together. The term assisted dying is confusing, and it's not surprising at all that the public are confused by it, and the reason that it's confusing is it has been adopted by people campaigning for assisted suicide to be legalised. If you'd come to me 10 years ago and said, "Do you do assisted dying?" I would have said yes. That's what palliative care is about. We assist people who are dying naturally. Assisted suicide was very clearly assisting somebody to end their life prematurely, either by taking oral medicines or by being given IV medications. They've used the term assisted dying because they know the term assisted suicide did not resonate with the public. People didn't really like that because people don't like to think that it's suicide. But if you're ending your life prematurely, that is suicide. And if you're assisting somebody to end their lives prematurely, you're assisting suicide. So, to my mind, the use of the term assisted dying is really unhelpful and misleading. And we have seen that from surveys in the public, that there are many people in the public who think assisted dying is what hospices do. They think assisted dying is palliative care. People who care for vulnerable people at the end of life, or who care for any vulnerable groups of people, find this very scary because there is so much uncertainty about it, and there are so many ways in which this could go horribly wrong, both for the individuals who think that they want it and for all of the individuals who would be directly and indirectly impacted. The idea is that this would be people prescribing oral medicines to people that they could take themselves that would kill them. And part of the challenge with that is that the evidence base is really non-existent in terms of what works. Some people take oral medication and they do die within an hour. Some people take the same oral medication and it is days. Sometimes it doesn't work. Sometimes they might be sick. Sometimes they might have a seizure. Sometimes they might become very agitated and distressed because of the impact of the oral medicine on them. There is no way to make this safe. I'm just putting that out there. You know, in healthcare, health and social care at the moment, we have countless examples of where well-intentioned legislation, policies have been put in place that have been misused, abused, have been misunderstood, misinterpreted, and poor practice has come out of it, and safeguards have been lost or overlooked. So that will happen with any legislation around assisted suicide. Safeguards will be swept aside. One of the safeguards is around prognosis and that you have a terminal illness. So immediately, prognosis is a very, very loose thing that we are very poor at establishing. Anyone who thinks that we can really accurately tell somebody's prognosis, that they're wrong. We can't. We know that. We've got ample evidence to show that doctors particularly are not good at guessing people's prognosis. We talk in ballpark terms. I have been in palliative medicine for over 20 years, and I have seen many people being given a prognosis which is very defined, and it's been wrong, either too short or too long. So there's a huge danger in using prognosis as one of the safeguards for assisted suicide. Another safeguard is the terminal illness. Why is it that we say people with a terminal illness have they're the only ones who suffer enough that assisted suicide should be offered? There are already people who are campaigning to say it shouldn't just be for people with a terminal illness. It should be for people with mental health conditions. It should be for people with chronic neurological conditions where you can have significant suffering. Why would those people be denied something that is a healthcare right for people just because you have a terminal illness? So again, it's, people talk about a slippery slope, and slippery slope is a terminology that is very easily dismissed by campaigners. But it is absolutely genuinely real, and we've seen it happen in a very short period of time in Canada. It is not possible to safeguard so robustly that people don't fall foul of abuse or misunderstanding or misinformation. And when the outcome is death, when the intention of that legislation is death, that's a really important thing. If we're saying we're willing to accept that risk so that a very, very small minority of people can have the choice to do this, when we know that so many people will be vulnerable to the misunderstanding and the misinterpretation, misuse of such a legislation. I think that's, as a professional, that's a risk that I feel I cannot be part of. I can't sanction, I can't say that's okay, because it's definitely not. I think saying that you can focus on both legislating for assisted suicide and focus on resourcing palliative care is misguided. So I think we can't do both. The idea that you could put more funding into palliative care and that would solve the problem, that as a care professional working in that area, I know that is wrong and misguided, so that will not solve the problem. As soon as we introduce assisted dying as a treatment, what you see in other countries where this has happened is that the evidence shows that the quality of end-of-life care and palliative care has reduced, and we cannot afford to be one of those countries that follows suit. And the impact on palliative care is that's the thing that worries all of the people who are working in palliative care at the moment is what would happen, despite the political sense. Oh, we would put more funding into palliative care at the beginning. Wouldn't that be lovely? But we absolutely have seen the impact of that in the long term. And there's no question that it would very negatively impact the wider access to palliative care for everyone. I think that one of my biggest worries with assisted dying is that if you catch people on a bad day and you hear that expression of, oh, I wish I wasn't here, I wish I was dead, and you act on that, then the opportunity for any further valuable life is gone. Because as soon as you hook into that expression of suffering and respond to it with an offer of death, that is immediately a destructive thing. You're saying, yes, I agree, your life has no value and never will, so we'll just let you die. And that's not what palliative care is about. So the Association of Palliative Medicine has done a couple of surveys now, anonymous surveys, asking doctors working in palliative medicine to share their views about assisted suicide, and it's very clear that doctors are concerned. The vast majority of doctors who currently work in palliative medicine are opposed to assisted suicide being embedded within healthcare. We have grave concerns about the implications of that. The vast majority of doctors fear that it would negatively impact palliative care and their ability to to support patients at the end of life. The vast majority of doctors think that it would affect recruitment. So if this was brought in Scotland, I think, as do many of my colleagues, that we would lose a lot of people. This will impact every single clinician working in palliative care if it's legislated. I would suggest it will impact every doctor, every doctor. It will become a treatment that has to be offered. It will become a healthcare right, and it will totally change clinical practice, because all of a sudden death is a treatment that you have to offer, when that's not what any doctor went into medicine to do. As soon as you respond to the expression of suffering with the offer of death, rather than the offer of relief of suffering with the potential of valued living, then that's healthcare that I don't want to be a part of. I think that's unsustainable. And anyone working in palliative care who has looked into it and who starts to see what's happening in other countries, I think would recognise that is a grave risk, and we're concerned about that. I think also there are concerns that while most organisations who provide palliative care would not wish to engage with assisted suicide, there are concerns that, as has happened in Canada, funding would be withdrawn, and so we would have to engage in some way. And I think the implications of, for example, working in a hospice where you had to support somebody who wanted assisted suicide, even if you weren't actually the ones to do it, having to call people into the hospice, the impact on the other patients, the families, the impact on the staff, that's all an area that we know so little about, and the experience that we see happening in Canada is that it is very negative. Putting assisted suicide forward as a medical treatment, I think that's would take us down a path that would distract us from where we really need to be headed, which is to ensure that everybody who is living with a terminal diagnosis has access to all of the support that they need to plan ahead, to identify what really matters to them, to know that the things that they value, the things that they want to, the treatments that they want to refuse, they have the ability to do that, to express their preferences, to have the conversations around that with healthcare professionals who they come in contact with, so that everybody is talking from the same set of values, the same set of ideas about what's realistic and what it is that's going to benefit that person. That relies on the resourcing of a whole host of care professionals, social care professionals, clinicians, nurses, therapists, volunteers. There are so many people that can make that work for an individual and their family. And that's where the attention needs to be focused, because right now we do some of that, but the amount of attention, political focus, the amount of resource that's focused on that is minuscule compared to other areas of medicine or of clinical practice. While the idea of enabling people to have this autonomous choice might sound good, it might sound like you're giving people a right and a choice that they deserve. The consequences of that is that you divert attention away from where people can really receive the right support. And so all of the people who are left in that area will be disadvantaged. We need huge political and healthcare focus on how we ensure that everybody in Scotland has equitable access to all the things they need to ensure good end-of-life care, to ensure living well with a terminal illness. And there are so many aspects to that in social care, in healthcare, in the third sector. How do you in the charities who provide funding for palliative care at the moment, making sure that people have really robust and equitable access to that should be the entire focus of people who want to improve end-of-life care.